for making this a topic for this symposium. So let me first. Also, okay. All right. That's my conflict of interest. So what I'm trying to do in this presentation is really try to pose some questions and find possible answers. So question one is, why could monitoring or surveillance of late presentation or late presenters in viral hepatitis be helpful? And the obvious way to look forward is to compare that to HIV. And you may know that it's now 10 years ago, so 1 decade that we have this wonderful definition of late presentation HIV infection, a consensus definition, which basically says late presenters are those with an HIV infection which upon diagnosis have already an advanced immune deficiency, which was defined as a CD4 count below 350, because at that time that was the starting point of antiviral therapy, or an AIDS-defining event, and then advanced HIV disease was called a late presenter with an even more advanced immune deficiency below 200 CD4 count. And that has, to the very day, been used in multiple surveillance programs, and probably most prominent by the European Disease for Center Control Agency, which can then sort of look not only overall, but between countries, between different sexes, regions, age groups, and HIV transmission risk groups. And you can see for here that indeed in Europe, still 53% of individuals with HIV are diagnosed late. And there is, though, as time goes by, issues with definitions. One clearly is the term late presenter, because people feel like they're being blamed for presenting late, and it's really more about a late diagnosis. So there's also a regrouping of experts to come to redefinition of this term. So there's a language issue. But if you leave that aside, you can see that probably men who have sex with men, which is a group which has a lot of prevention services, an active community, there's more knowledge around transmission of HIV, and as such, the amount of people who are diagnosed late in the MSM context are going down quite steadily. And remember that the introduction of pre-exposure prophylaxis, giving people the possibility of controlling their own sexual health, has really promoted HIV testing, because in the standard application of PrEP, you do that every 3 months, and as such has changed everything. And you can monitor that over time and compare countries. And the reason why Europe is doing so bad for HIV is obviously because of stigma and criminalization of certain transmission risk groups. But that is a different topic. So how could we use this knowledge from HIV and transcend to a definition in the field of viral hepatitis? So the question 2 was, how is late presentation for medical care of viral hepatitis defined? And that was a cumbersome process. And you may know an initiative which is called HIV in Europe. HIV Europe is an initiative which is a constitution of stakeholders from the public health area, community activists, and treating physicians, patient representatives, who all together are trying to prevent late diagnosis. So really trying to find the people living out there with HIV to get treatment, because if you're on treatment and undetectable, you're not transmittable. And obviously also for the individual benefit to get people on therapy. And so the idea was, with the awakening of better treatment options for hepatitis B and C, it would make perfect sense to duplicate this presentation. And so this group reached out to EASL, the European Association for Study of Liver Disease, and got prominent figures involved. It was a strenuous process, put it that way. But in the end, we came up with a definition which basically says that a patient with chronic viral hepatitis B or C and significant fibrosis, and that's probably the complicated part, because you can use different non-invasive markers for fibrosis assessment, but this is also an advance, right? Because in the old days, we were left with liver biopsy, which no one really wanted to do because the consequences were often low in the absence of good treatment options. But now that we have good treatment options and non-invasive markers, which reliably allow at least to discriminate those with cirrhosis, so very advanced disease, and early fibrotic stages, it becomes more attractive. The only problem is that everyone is using a different scoring system. And how do you capture that correspondingly can be an issue. But I would say that for those who have the low income background, at least an APRI score, which is a liver value in platelets, something which commonly is accessible for most, can be used. And then there are more elegant tests, which our French colleagues have developed, but are also implying a certain surcharge. And then there's obviously technology like the FibroScan, which is an ultrasound-derived device, which allows measurement of liver stiffness and also relatively reliably allows to separate no fibrosis versus more advanced fibrosis. But you can see that all of that correlates to having either F3 or higher grades of fibrosis. So it's really more advanced fibrosis stages which are fulfilling the definition of advanced liver disease in untreated patients. And then late-stage liver disease is someone who has decompensated cirrhosis, which is characterized by the typical clinical signs of decompensation, so ascites or occurrence of rectal bleeding and other events. So what are the challenges with the current definition? And more recently, there has been an ongoing discussion with the hepatology societies, also with your colleagues from Geneva, which are trying to sort of highlight that the definition has one issue, because you have to better define probably when is this fibrosis stage assessment made? Is it upon initial diagnosis, or is it when the patient gets into care? And so for many people, they may have been diagnosed at a certain time point, but in the lack of treatment modalities, were left untreated in care and then eventually make their way to a treating center or hepatologist or a sort of derived care model with better treatments available. So that is something which messes it up, because if you're from the old interferon time, a lot of people said, I'm not going to go for this treatment, side effects, low response rates, so I'm going to wait. And then when they then enter care and get assessed for treatment, then that fibrosis stage is used. But that's a different thing if you already have a duration of 10 years, because obviously then you're going to tend towards a more advanced liver disease stage. So that is something which probably needs to be corrected. And then in contrast, when the HIV physicians got together, there was really huge enthusiasm to develop the definition, because countries really wanted to compare and they wanted to see how are the goals. And remember that in the HIV world, you're always trying to achieve the WHO UN AIDS goals. So that was 90, 90, 90. Now it's 95, 95, 95. And so obviously getting 95% diagnosed is already a big threshold. You want to know how many of those who are diagnosed late, because if there is a large proportion of late diagnosed people, means you have still many people out there who are not diagnosed. And the less that becomes, the more likely you are to have a better capturing of the individuals who are all living in your country with HIV infection. So I think that remains a problem, because hepatologists were not equally enthusiastic to get the definition on board and use, which has been, I think, a challenge, at least for a while. So how has that definition then been used? Let me just see when that was. So 2017, the definition was published. And so the first thing was obviously that in our group, we thought, well, we developed the definition, so we're going to look in the different treatment cohorts which are emerging into how does that sort of play out. And one is the German Hepatitis C register, which was going to look at how does free access to DA therapy. So everyone with health insurance in Germany was at least a possible candidate for DA therapy. And the question was, if we would roll out and treat everyone, are we going to see less and less late presenters? That was sort of the hoped outcome and hypothesis. Obviously, under consideration that progression of fibrosis eventually occurs and that there is an increased morbidity mortality, and so preventing late presentation overall appears to be a positive thing. So anyone who was above 18, signed informed consent, had hepatitis C, was not treated previously with any other regimen, sort of was entered from 2014 onwards to the end of 2018, which had 5 observation periods. And one of the issues was that the funding for the register intermittently was gone for a while, so there was a certain brief interruption. So that time frame in 2016, some months were not captured. That has been excluded from analysis correspondingly. Now, there was no recommendation for any DA therapy or for those who had HIV, any combination antivirals. That was all at the discretion of the corresponding investigator. You can see that over 250 centers in Germany participated, reaching to almost 18,000 patients. And if you look at those without any pre-treatment, so that was 8,000 individuals, and of those, around 550 were HIV co-infected and 7,452 were hepatitis C mono-infected. And you see the display of patients over the observation period and the breakdown by year. So that was the consensus definition we used. And then you can see that advanced liver disease was sort of fulfilling depending on what the participating center, including the patient to the register, used, whether it was FibroScan or liver biopsy or an APRI score was all used, or it was liver cirrhosis, which then all fell into the definition of late presentation. And when you look at the overall total numbers, you can see that indeed 28% fulfilled the criteria of late presentation in the group of hepatitis C mono-infected, and it was 24% in the group of co-infected patients, which is a quarter of patients, which really tells you that obviously a lot of people come really late, because obviously what you want to do is with early treatment prevent more serious fibrosis stages. So clearly room for improvement or things to do. And then you see this breakdown over time, which shows you for mono and co-infected and the total population, how late presentation developed over time. And it's kind of interesting to see indeed that you see a decrease over time. And the reason for that is most likely that obviously when new treatment forms become available, you're most willingly to treat first the most advanced patients because they've been waiting for better treatments. And so they sort of get into the first cycle, and then it sort of steadily decreased, which means that the amount of people with more advanced liver disease were getting less and less, which also means that probably less new people were diagnosed with advanced liver disease. And then you see there's a little increase again in 2018, which I think has something to do with the fact that genotype 3 patients were left a little bit out of the initial treatment strata because of the regimens, which were more genotype 1-4 based and did not allow good. So I think a lot of genotype 3 patients waited a little bit longer for that reason. This is the genotype distribution. And indeed, you can see that genotype 3 in 2018 is a relatively large bulk, as well as in 2017, sort of resembling that these genotypes with pan-genotypic drugs becoming available were sort of treated a little bit later. And you see that indeed genotype 1 is on the declining side, as obviously already the very first DA-based therapies targeted genotype 1 infections accordingly. And if you look at the late presenters comparing mono and co-infected patients, there are some subtle differences. First, if you concentrate just on what separates those with advanced presentation from those with minimal fibrosis in the mono infection, taking into consideration that this is a large number of patients, you can see that obviously it is an older patient population, as you would think. So the older you are and the longer your duration of hepatitis C infection is, the more likely you will be to present late, which makes obviously perfect sense with the natural course of hepatitis C. And if you compare to the HCV co-infected individuals, you can see that they are on average somewhat younger, and following the demographics of the HIV transmission risk groups in Germany, you can see that there is a predominance of male sex, which relates to the high proportion of MSM in the German HIV cohorts. You can see that they also have a somewhat lower BMI, and you see that the genotype distribution is also a little bit different, which probably resembles that there is a higher group of genotype 4 infections in MSM, and then there are also some genotype 3 infections, which probably are more around HIV positive intravenous drug users. Now, the treatment outcome overall, as anywhere in the world, has been very good, and reassuringly also between mono and co-infected patients, not too much difference on the setting of no or minimal fibrosis. You can see that there's a cure rate of 96%, which in a very large real-life cohort, I think is very reassuring that outside of clinical trials, you really see excellent overall response rates. And then similarly high response rates in more fibrotic patients, a little bit lower in the HIV co-infected individuals, but remember, these are then also smaller numbers, and I wouldn't say that that would lean to statistical analysis. The GECKO cohort is a German cohort which is outside of the German hepatitis Register. So this was an initiative from mostly HIV providers who also, though, took care of HIV mono-infected individuals and then looked at their patients and compared them. There were 653 mono-infected patients and 210 HIV hepatitis C co-infected patients, so a little bit smaller, obviously a lot smaller than the German register, but still interesting to look enough also because of the high number of HIV co-infected patients. And here you see, again, over time from 2014 to 2017, sort of how advanced liver disease is least declining over time. And those with no or minimal fibrosis receiving treatment or presenting are clearly increasing over time. So less advanced patients. And that's what you would expect if there's a rollout of DA happening in your cohort. And if you look at those again with advanced versus no fibrosis, then you can see that the patients with no fibrosis are younger, no difference with regard to sex. And you can see that the amount of people with men who have sex with men as a transmission risk group are much higher, which tells you that in those with no fibrosis, you probably have a bias because you have many people with recently acquired hepatitis C which enter the cohort. And as you may know, we had a huge outbreak, just similar to Switzerland, among the MSM community, and that sort of accounts for a lot of the new infections and also for a lot of the no fibrosis infections, and that also accounts for some of the differences in genotype distribution because there also have been other genotypes than genotype 1, which is the predominant German genotype. And you can see that the years since diagnosis are obviously much shorter, with 2 years versus 5 in the ones without significant fibrosis, because clearly time is a main factor in fibrosis development. So if you look at the risk factors for advanced liver disease at time point of hepatitis C treatment initiation, then you can see it is the genotype 3 versus genotype 1 to 4, because genotype 3 was more difficult to treat and you had to wait longer. CD4 count may play a role. MSM is obviously leads to earlier treatment because you also treat recently acquired. Intravenous drug use often means that people present to care later. And people with blood products, in our context, are mostly hemophiliacs, which often have the longest duration of hepatitis C, the most advanced disease, and it took a long time before treatment options emerged for this patient population altogether, and then obviously duration of treatment. So if you summarize these two cohorts, you would say that a quarter of mono-infected individuals are late presenters. There has been a decrease in late presentation since 2014. There's risk factors are higher age, longer duration of untreated hepatitis C, male sex, and genotype 3. Patients with HIV co-infection are on average younger, have a shorter duration of hepatitis C infection, more frequent genotype 3 or 4, and a lower BMI. And late presentation in MSM is rare, no wonder, because it's a recent introduction of recently acquired, and it's just not so much time to more advanced fibrosis development. The limitation of these two cohorts is that obviously what we're looking at are people who get assessed upon treatment initiation. And that is the criticism of your Swiss colleague in Geneva, because they basically say you have to do it upon initial diagnosis and not when treatment is initiated. So that's something to keep in mind for discussion. Now, obviously, those were humble attempts. The definition emerged, DAs became accessible, and that's how we sort of played around with the definition. And now, if you go into literature, after years where there, like the first 2 or 3 years, there was very little cohorts which used this, there's now an awakening interest, and I came across a whole range of papers, and I wanted to just shortly present 3 papers. One is from Spain, and it's currently in press, and it's looking at the description of hepatitis B and hepatitis C late presenter patients, and it's sort of comparing, if you look at the odds ratios, what plays a role. You can see that age plays a role, as you would expect. For me, what I didn't understand is why Spanish-born also comes with a risk factor. But that was another emerging factor. And if you look at the overall amount of people who present late, then it's 25.7%. So interesting, very similar to the German data, suggesting that indeed a quarter are relatively advanced. And you can see that those have F4 is 15.7. If you look at the late stage liver disease, so that's clinical symptoms suggestive of decompensated cirrhosis, is around 5%. Hepatocellular carcinoma is around 2%. So it tells you in a different cohort that there's also around a quarter of patients with advanced or late presentation. And then there's a smaller study from Denmark, which looks at 540 people, but not everyone had a fibrosis assessment, so it's a little bit smaller group. And they also looked at various factors which were associated with presenting with late-stage liver disease. And you can see that the only factor in multivariate which ended up being significant is in the bottom line, is history of intravenous drug use. And I think that's a very important point because it highlights that certain vulnerable populations or patient groups are sort of left behind. And I think that's one thing we see in our context in the university hospital, where, let's say, the person with past history comes for treatment, but people with ongoing drug use rarely make it to a university hospital. And that has a lot to do with stigma and the way they're treated. And I can tell you, as an example, a couple of weeks ago, I had an individual come into the clinic and he goes to the receptionist and says, I want to be tested for HIV and hepatitis. He doesn't have an appointment, he has no referral note. And so the receptionist is like, you do not belong here. And the doctor said, we have no time and blah, blah, blah. And I said, well, I'm the consultant, so I always have time because I'm working at a German university hospital, which basically means you have nothing to do. And so I'll see the patient. And basically what turns out, he obviously is in a substitution program, but is sharing needles and using heroin on the side, and was agitated. And you know that these people do not have a lot of time for either it happens now or never. And so I drew blood, I did a test, and it turned out he has an acute hepatitis C. So a perfect point of intervention. And the problem is, though, that it's all missed because there's such a hostility against the person seeking care, because basically he was afraid of contracting something because he had to risk exposure. And I think that's one of the big problems. And I see that a lot of people in a more substitution setting are not referred for hepatitis treatment. So I think intravenous drug use remains a huge barrier to treatment because they are often in a setting where they either not get referred to treatment or there are other issues. And it can all change. My wonderful colleague who worked with us for over 20 years is now in private practice. And she actively went to all substitution centers and said, I am, the new person, and in a very non-threshold, no barriers setting, I'm willing to treat them all. And now they're referring them, and the individuals feel very comfortable. And so suddenly the people being treated has increased substantially, because one person is different. So it's interesting to see how you as a physician can make a huge difference by creating a more tranquil, accepting environment. So that, I think, is, though the story here is that indeed history of IV drug use is an important screening tool which needs to be used and employed accordingly. And then there's a wonderful study which was just published in Liver International from French colleagues. And that's very interesting because they did everything right in contrast to us, because they basically said, we're going to look at the correlates of late presentation, and we're going to look at all our patients in our cohort, which are 9,100, which of them have data on fibrosis stage at first presentation. So they did the right correlation, right? So they looked when were they the first time diagnosed, and do we have data which allows us to assess fibrosis stage at that time? And that was only possible in a fraction of individuals, 1,236, but at least that is a substantial number. And of those, 47% were late presenters, so F3 or higher fibrosis. And that's an alarming sign. That means there's a huge amount of people out there who actually have advanced liver disease, which relates to what you've been saying, that people are suddenly admitted and have very advanced fibrosis stages. And in their multivariable analysis, where they adjusted for age, sex, genotype, and so forth, they found that current alcohol use, current abstinence, but past hazardous alcohol use, and were all independently associated with late presentation and diabetes. And that makes perfect sense because hepatitis C causes insulin resistance and the rate of diabetes is higher. So what they're basically saying is that In the French setting, it would make sense to ask, did you have a period of more alcohol abuse? Yes, no. And diabetes, yes, no. And then potentially screen all of those people for hepatitis C. And then there would need to be a need for cost effectiveness analysis. But if you would diagnose them earlier, you would save all the money from the corresponding late stages and the morbidity and mortality arising from that. My wonderful colleague, Jenny Bischoff, who's putting all these papers together, did a map and looked at various studies. So on top, and you can see that really, on average, I would say at least a quarter to a third of patients are probably fulfilling the definition of late presentation, depending on how you use it. But I think it does send an alarming signal that this is something of concern. So how is the European hepatitis monitoring on late presentation working? And I thought I would include this because ECDC has also been trying to set up a monitoring system to support countries monitor progress towards elimination targets for hepatitis C. And they collect data on responses to hepatitis B and C epidemics. And they have their first data collection, which they presented now at various meetings. And these are the results from some of the first data. And they looked at end-stage liver disease, which though was made by including cirrhosis and hepatocellular carcinoma. And you see for the various countries, the figures there. So depends very much probably where you are, that it's not always the same, but you can see, depending if you look at this more advanced definition of cirrhosis and HCC, obviously then you're going to miss all the earlier fibrosis stages, F3 and so forth, then it's lower, but you can also see there are countries like Romania with very high numbers of very advanced liver disease. And the estimated prevalent proportion of diagnosed cases with decombinant cirrhosis ranges from 2 to 40%, for C5 to 27%. So I think they're understanding the need, and they're now reworking their definition and discussing how to best monitor this. And there will be a huge surveillance program starting next year to look at issues around late presentation in Europe. The last question I was asked is obviously, so how is the COVID-19 pandemic going to impact late presentation of individuals with viral hepatitis, and how will that all be? And I don't have the time to go through all the data which is available for that, but I just wanted to highlight two issues. One is that obviously testing services